All right, so what we're going to talk about today is hydrocephalus. A lot of you know what that is. It's a very serious condition, right, that many children face after large epilepsy surgeries. But what are the effects of hydrocephalus if diagnosis is delayed or management is challenging? And Dr. Tyler is going to talk about that today. But first, I just want to tell you, he is, as you see on the board, a pediatric neurosurgeon specializing in epilepsy surgery. He's the surgical director at the Pediatric Epilepsy Surgery Program at UPMC Children's Hospital of Pittsburgh. Dr. Abel is from Seattle, Washington, and completed his undergraduate and medical education at the University of Washington. After his medical education in Seattle, Dr. Abel completed his neurosurgery residency at the University of Iowa Hospitals and Clinics, where he received specialized training in epilepsy surgery and brain mapping techniques. During his time at Iowa, Dr. Abel completed a NIH-funded postdoctoral fellowship focusing on human brain electrophysiology, specifically the identification of higher cognitive functions such as language and visual recognition in patients with epilepsy. Dr. Abel joined the University of Iowa as an attending neurosurgeon after finishing his residency. His clinical interest is in pediatric neurosurgery and epilepsy surgery. He completed an epilepsy surgery fellowship in Grenoble, France. And in Grenoble, Dr. Abel received special training in the identification of epileptic foci using stereo electroencephalography and the use of the ROSA robot for epilepsy surgery. Dr. Abel completed a pediatric neurosurgery fellowship at the Hospital for Sick Kids in Toronto, Canada, focusing on epilepsy surgery, neuro-oncologic surgery, craniofacial surgery, and endoscopic techniques. And finally, Dr. Abel serves on the board, on the scientific advisory board of the Brain Recovery Project, the Childhood Epilepsy Surgery Foundation. And here he is.
Thank you. Thank you very much. That's the most generous introduction I've ever gotten. That was great. Thank you very much. So my name's Taylor Abel. I'm a pediatric neurosurgeon and an epilepsy surgeon at the University of Pittsburgh and Children's Hospital of Pittsburgh. And today I'm going to be talking about hydrocephalus. One of the things that I actually inherited this talk late, but one of the things that the talk prompted was talking about when treatment for hydrocephalus should start. And I'll share my opinion on that, among other things. I first just want to thank you all for inviting me here. I have learned so much from interacting with the families here and the patients here. This has been a tremendous experience. I've learned a lot. And also, I'm thankful to be here because on my way here, I was in a car accident. And so I was actually, my car was totally stopped on the freeway and I got rear-ended at highway speed, and that is my car. So it took me an extra 6 hours to get here because I had to get a rental car. My goal is actually just to talk about hydrocephalus really quickly and to try to hit some of the highlights and then to have as much time as possible so that we can just talk. I'm going to talk about these things. I saw some of the previous speakers that have given this talk at this conference before kind of covered these general topics and then talked a little bit about hydrocephalus more specifically with epilepsy surgery. So I'll briefly talk about all those things. I'm going to try to get through it in 15, 20 minutes, and then just we can maybe do some questions. I'll start with a case. This is one of the first patients I took care of when I got to the University of Pittsburgh. This is a child who began having seizures at 4 days of life and had this small abnormality that was detected on an MRI that was obtained at 4 days of life. And unfortunately was not referred to a neurosurgeon. And at 8 months, the child came back to the hospital to get their follow-up MRI, and that's what had happened to the tumor. And so what you can see, this child, I just want to mention, still was not having any seizures. The seizures had occurred in the neonatal intensive care unit. They were controlled with medications, and the child was just coming back for a follow-up MRI. And so I was actually called emergently by the anesthesiologist who was looking at the scan and said, let's get a neurosurgeon down here. But we actually woke the child up from the scan, and of course, we did an operation. But the reason I'm showing this case is because it's going to illustrate some of the principles that we're going to talk about with something that we more broadly called postoperative hydrocephalus, or hydrocephalus that occurs after surgery. We're going to be talking about a specific instance of postoperative hydrocephalus specific to epilepsy surgery. But this is a situation where I've had to watch for hydrocephalus pretty closely. And the reason is because when you remove that much tissue from within the skull, you get all these changes in the fluid spaces in the brain. And so what you can see here is that the subdural space, that space on the outside of the brain, has filled with fluid, and in this case, that dark stuff up at the top of the screen is air. So there's fluid in there, there's air in there, there's a little bit of blood in there, and then if we were to look lower down on the scan, you can see that which we won't do, but lower down on the scan, the fluid-filled spaces of the brain, called the ventricles, are also enlarged in size. And so a lot of things are changing, which can lead to the overaccumulation of fluid in the brain. And so I've followed this child every 3 months from surgery, not only to make sure his tumor does not come back, but also to monitor for hydrocephalus. And the reason for that is because this child has a number of things that can cause hydrocephalus. There's been bleeding in the brain, there's been inflammation in the brain, there's been a removal of a large area of tissue which can cause fluid in the brain to go to abnormal areas. For example, this is at 10 months and then 15 months. You can see that there's fluid on the outside of the brain, which is not normal. The ventricles are a little bit larger than they would normally be. So these are all things that we have to monitor very carefully, not just after epilepsy surgery, but after any kind of surgery where we're doing really big removal of tumors or seizure foci, anything like that. So what is hydrocephalus? It is simply the accumulation of brain fluid in the brain. And we'll talk a little bit more about that, but our brains all have fluid. If you're an adult, you have about 150 cc's of fluid in your brain and spinal cord right now. That circulates through about 3 times a day. So every day you make about a half liter of this fluid. And it kind of helps cushion your brain so that when you jiggle your head, you don't get a headache. Oddly enough, if you have a spinal fluid leak, those of us that have had children, which is almost a lot of the women in the room, you may have had a headache after you had your epidural, right? That's called a post-lumbar puncture headache, and what causes that headache is that you lost spinal fluid. And so when your head moves, your head hurts because your brain's moving a little bit more than it normally would. So hydrocephalus is one of the most common things we see in pediatric neurosurgery. So about 50% of what I do is actually hydrocephalus surgery. Medicine does not work. Sometimes you can give a medication called Diamox, which can help slow the production of spinal fluid, but it's really a temporizing measure, and it doesn't work for real hydrocephalus. Surgery does work. We'll talk about some of the risks and benefits of doing that. Certain types of hydrocephalus can be transient, meaning it can come and then go. But once you have a diagnosis of hydrocephalus, it kind of stays with you. It usually does not get better. The types that get better are if you have bleeding in the brain. When the bleeding goes away, sometimes the hydrocephalus will get better. Or if you have something that is obstructing the normal flow of spinal fluid. When that obstruction is taken away, whether it be a tumor or a blood clot, your absorption of spinal fluid will return to normal and your hydrocephalus will get better. What are the symptoms of hydrocephalus? Headache, poor feeding, nausea, vomiting, head growth more than expected, eye movement abnormalities, and then these are things that we don't, we try to avoid: vision loss, and then eventually coma and even death. This can be a life-threatening condition. There are different types of hydrocephalus. This I would consider to be simple hydrocephalus. The reason this is simple is because there's one cavity of fluid in the brain. This is a child who happens to be treated with a shunt. We'll talk a little bit about that in a few minutes. The catheter is in that one fluid space, and that's going to treat the hydrocephalus. This is actually a child who's having a shunt malfunction. This child's ventricles are usually a lot smaller. I ended up doing surgery for that shunt malfunction, which is something that unfortunately can happen with shunts. We'll talk a little bit more about that also. Hydrocephalus can also be very complex. This is an example of post-infectious hydrocephalus. This is a child who had a really bad infection after they were born, and they were still in the NICU when they had this infection. And what happens is when there's inflammation in the brain, it causes all these walls to form in the ventricle that are not normally there, and those walls cause these loculations. And so this is called multiloculated hydrocephalus. The only way to treat this is either by putting multiple catheters into all of those holes, which, as you can imagine, is really difficult because there are a lot of loculations and spaces there. Or you can go in with an endoscope and poke holes in each of those septations to try to get it to be one big cavity, which is typically how I approach this. And that's how I approached it in this particular child. The next slide is a little bit disturbing. I'm going to show what happens when hydrocephalus is not treated. So I would just warn you, it's not a pleasant slide to see, but I just want you to see a picture of what happens when these children are somewhere where they can't be treated. This is a child that before I had kids, I used to go to Africa and do pediatric neurosurgery there. Sub-Saharan Africa has only 3 pediatric neurosurgeons for a huge population. This is a child that I took care of who had severe hydrocephalus and had no access to a neurosurgeon that could look after her. You can see that her head is very large. You can see that she is unable to look up. Her eyes are deviated downward. And if you look on the side of her head, she unfortunately has these ulcers on the side of her head because her head is so heavy and she's not able to move her head on her bed when she's laying down. And so she gets these skin problems on the side of her head. And you can, if you look at the complete picture, she also happens to be malnourished because she's not able to keep food down. And so, unfortunately, this is what happens without treatment in young babies. I'm going to talk a little bit about how spinal fluid typically works. Spinal fluid is made in the, let me see if I can actually, does this thing work? Barely. So spinal fluid is made in the lateral ventricles here. It's made by something called the choroid plexus. It then flows downward into the third ventricle and then flows down out to the fourth ventricle, where it then exits through they call it the lateral aperture. It's called foramen Ilushka, but it's just a small hole where the spinal fluid then exits and then goes to the top of the brain where it then gets absorbed. And of course, it's not necessarily important to know all those details, but it'll be helpful when we talk about how some of these things can be treated. And the principle is that the CSF that gets made, those 500 cc's every day that your brain makes, it also needs to get absorbed. And if it's not getting absorbed, you're going to get an abnormal accumulation of spinal fluid that we call hydrocephalus. The reason why abnormally accumulating fluid is a problem is because the brain is contained within the skull. And so if you flex your muscle really big and all this blood flow goes to your muscle and your muscle expands in size because of the fluid in it, that's okay because your muscle doesn't have a skull around it. The problem with the brain is that the brain is confined in the skull, and so the volume within the skull has to remain relatively constant, and if it doesn't, you'll get increases in pressure. And so the intracranial space, that's the space within the skull, is made up of these three components: the brain, of course, spinal fluid, and blood. And when any of those spaces increase in size, as the volume increases, the pressure increases. And what this curve shows is that you can do really well for a while. This is why it takes a while to get sick if you have hydrocephalus. You can, your fluid can accumulate, and you'll be going along on this curve where the volume within the skull is increasing, but then when you get here, things change really fast. And so that's why you can actually do well for a while when you're accumulating this fluid, but after things get to a certain point, you're going to become really symptomatic very fast. And when you get to this part of the curve, and things are really shooting straight up like that, that's when it becomes life-threatening. And so that's a situation you don't ever want to get to. Another thing I'll just mention quickly is the reason why babies get really big heads and are able to live so long with untreated hydrocephalus is because babies their skulls haven't fused. So rather than the pressure going up, their skulls just get bigger. And that's why babies that have untreated hydrocephalus have very large heads. But that doesn't happen after your skull bones have fused. There are three things that cause hydrocephalus. One is having too much production of spinal fluid. That's caused by certain brain tumors that secrete spinal fluid called choroid plexus papillomas. It's not very common. Another cause is obstruction of a CSF pathway by, say, a tumor or a blood clot or something like that. And the third, which is probably most pertinent to our discussion of postoperative hydrocephalus, is impaired CSF absorption. So when you have inflammation in the brain or you've had bleeding in the brain, sometimes the inflammation will get to that top part of the brain where the spinal fluid is absorbed, and it'll cause some blockage there, so that even though you're making a normal amount of spinal fluid, that spinal fluid just doesn't get absorbed. And so there are different etiologies or causes of hydrocephalus, and the condition we see most frequently is something called intraventricular hemorrhage of prematurity. And so we've become really good at getting really young babies to through their NICU experience, even when they're born at really early on, like 24, 25 weeks. But many of them, their brains are not ready to be outside of the womb, and so they get very stressed after they're born, and then they have brain hemorrhages. Another cause is post-infectious hydrocephalus, which is the most common cause in Africa, along with myelomeningocele. Myelomeningocele used to be really common in the United States, but now is not very common because we take prenatal vitamins. And then the fourth major category is any kind of trauma. So after a brain injury where there's bleeding in the brain, you can get post-traumatic hydrocephalus. I've seen it even when there's not much bleeding in the brain. You can get hydrocephalus after brain surgery of any type, though it's unusual with most types of brain surgery. Hemispherectomy that's not the case, which we'll talk about in a little bit. You can even get hydrocephalus after spinal cord surgery. So if there's enough debris or bleeding from a spinal cord surgery, that debris can go up and cause blockages at the top part of the brain. And so hemispherectomy, actually, we'll go to the next slide first. This is the first description of persistent intracranial bleeding as a complication of hemispherectomy. That's something we now know as hemosiderosis. where you can get this micro bleeding after an anatomic hemispherectomy, which is where you remove the entire cortex rather than just disconnecting it. And that can cause problems with absorption of spinal fluid because those blood products block where spinal fluid is absorbed. And this is actually the first description, which is, I think that's 1966. The lower picture is a ventriculogram. This is back before we had MRIs or CT scans, and so the way they used to get images of the brain is they'd inject air into the ventricles through the spine, and that's the kind of picture you'd get on an X-ray. But you can see that on the right, the ventricles are very large from hydrocephalus, and you can see that half the cerebral cortex is missing. So that's been one of the main reasons why people have moved away from doing anatomic hemispherectomies, where the cerebral cortex is completely removed, and have moved towards doing these more selective disconnection approaches. And so you can see here kind of the evolution of these different techniques. On the left is an anatomic hemispherectomy, with the one on the very right side of the screen being purely a disconnection, where not much, if at all, is removed. So, big question, how many children are going to have hydrocephalus after a hemispherectomy? And I think the answer is we don't really know. But what the literature would tell us is it's probably about 20, this is 23% here in a very large multi-center registry. It's about a quarter in the literature. My guess is that if we're really careful, we can get that number to be lower. And I'll talk about why in a few minutes. And then the other thing I'm showing is that there's a huge heterogeneity in what's actually reported. This is another report I found that reviewed the literature, and these are actually fairly large hemispherectomy series, which are showing pretty low rates of hydrocephalus. I think some is, I actually can't even see the slide from there, so that means that none of you can either, and I'm sorry about that. The range there is about 2% to 33%. And so what that means is that there is probably this really big range because the way we're doing hemispherectomies is very different from center to center. I'll talk about some of the things I do to try to reduce the risk of hydrocephalus. But I think the point here, though, is that there are things we can do to reduce the risk. And how to treat postoperative hydrocephalus. Defense wins championships. And what I mean by that is the best way to take care of a complication is to prevent it from happening. And even if we do a perfect job, maybe we won't be able to prevent every incidence of postoperative hydrocephalus, but most important thing is control bleeding. This is something that we do take very seriously in pediatric neurosurgery because I've operated on patients who are 500 grams. So bleeding is a really big deal when you're doing surgery on a child who's so small. So control bleeding. Do it step by step through the operation. That is certainly something that's more important for me to tell my trainees than it is to tell this group. But the other thing is I try to avoid chemical hemostatics. So the military and other groups have gotten really good at developing these, what we call chemical hemostatics, which are these agents that we can spray onto the brain that are really good at stopping bleeding. And it's really tempting to use those products, but the problem with using them in this situation is that they can diffuse to the top of the brain and cause blockages there. They're really good at stopping bleeding, but they're also really good at stopping flow of other fluid like spinal fluid. And so that's actually been identified as one of the risk factors in that multi-center study by Sean Liu. And then do everything you can to reduce debris, which you just irrigate over and over and over again. And then the other thing that we do at Pittsburgh is we leave a drain in the ventricle. and we keep draining fluid until the fluid is clear. And then after we do that, we slowly raise the drain and get a scan or watch the patient very carefully to make sure that there's no abnormal spinal fluid output. And I think those things help a lot, I think. Exactly how much, we don't know. And unfortunately, we probably will never find out because ultimately, hydrocephalus after hemispherectomy is a rare enough condition that to get the numbers necessary to do like a comparative clinical trial for something like this would be pretty difficult. Even without evidence, though, these are things that I would do. Treatment options. How do we treat hydrocephalus? The most tried and true way is something called a shunt. We'll talk about that in a little bit. That is the most common way to treat hydrocephalus. There is also something called an endoscopic third ventriculostomy. We'll talk a little bit about that. That's a way of avoiding a shunt. And then the third thing, which I've only done I've done it twice, once in Africa and once in the United States, is something called a microsurgical choroid plexectomy. That's where you actually do an operation under the microscope and you surgically remove the choroid plexus, which is what makes the CSF. I've only done that in palliative situations where our goal was not to, was really to make it possible for a child with a very difficult to control head size to be able to go home with their family, which is a very unfortunate situation. This is a ventriculoperitoneal shunt. We have a lot of different types of shunts, but the principle here is that you have a tube that goes into the brain, into the fluid-filled space of the brain, and then it's connected to a valve so it doesn't drain too much fluid. It's then tunneled under the skin into the peritoneum. And if there's a problem with the belly, you can put it actually in the heart. The heart can handle as much fluid as the brain can produce. And the other place you can put it is actually if the child is old enough, you can put it in the lung also. The pleura, the space outside the lung, which absorbs a lot of fluid. One of my huge pet peeves in neurosurgery is this idea that a shunt is an easy operation. And so when I was in residency, maybe you don't. Anyway, the point is, this is something that needs to be taken seriously. Even though it's an operation that every neurosurgeon does, it should be taken very seriously because even though it's a straightforward operation, it's a really important operation. The reason it's important is because even when it's done perfectly, so many things can go wrong. So infection rates used to be 7%. With a lot of research and hard work by pediatric neurosurgeons over the years, we've gotten our infection rates down to 4 to 5%, but that is still a high infection rate. Some research would suggest that every time you have a shunt infection, you lose 10 IQ points, right? That's something that we don't ever want to see happen. So we do everything we can to prevent shunt infections. The more common problem you can have is something called a shunt malfunction, which is where you have a blockage of some part of the shunt. And you can have a proximal block, which is the most common. That's where the part that's in your brain gets blocked up by debris. You can also have a distal problem, which is where the part down your belly gets blocked, or you can have the valve get clogged. Malfunction is unfortunately extremely common, and we haven't been able to do much to improve our shunt malfunction rates, even though we've been doing shunts since the 1950s. So it's about 50%, even shortly after the operation. And so oftentimes with a shunt, you end up having multiple operations. I have operated on people who have had like 26 shunt revisions over the course of their life. I have partners that have been doing neurosurgery for 30 years that have patients who have had even more than that. So those are extreme situations, but the point I'm making here is if we can avoid a shunt, let's avoid a shunt. And so the reason I wanted to make that point is part of today's prompt was, is early intervention critical? And it absolutely is, but treatment without a good reason is something that I would not advocate for, because the morbidity of a shunt is very high. So even though it's important to treat hydrocephalus as soon as it's clearly diagnosed, I would certainly not treat with a shunt before then. If I'm uncertain about whether or not a child has hydrocephalus, then I'll typically offer a family something called ICP monitoring. That's where you can put a pressure monitoring device into the skull and monitor pressure. And I will do it for days until we really have a better answer about whether or not there's hydrocephalus. The other thing I'll do is I'll monitor children very closely, have them come back every couple weeks if there's a question. But most of the time it is pretty clear whether or not hydrocephalus has occurred. So we also have these endoscopic options, which have gotten really good with advances in endoscopy. One is called an ETV. We kind of talked about that. That's an endoscopic third ventriculostomy. I'll show how that looks like in a moment. I've never done an ETV for a child who's had a hemispherectomy, but I've met two families since being here where their child has had that done, and it has appeared to be successful. And so that is potentially an option. And so that's something you should try to be at a center where they use all these techniques. The other thing that's important to work with a surgeon who has experience with fenestration or septostomy using the endoscope, because that's something that also might be important in treating post-hemispherectomy hydrocephalus. And just to illustrate what an ETV is, you can see here that a lot of times after there's been bleeding in the brain, you get some scarring in the cerebral aqueduct, which is how fluid gets from the third ventricle to the fourth ventricle. So I think you can appreciate here that the third ventricle is quite large, but the fourth ventricle is relatively smaller. And so what that means is that there's at least a little bit of a blockage here that you can maybe bypass. And the way you bypass that blockage is by putting a small camera into the ventricle all the way down to the floor, then poking a hole right here. And when you poke that hole, rather than being blocked and accumulating, the fluid will now go through that hole, go around to the top part of the brain, and get absorbed there. And so it's a way of bypassing the blockage that's been caused by the scarring. This is actually a child who I could not do an ETV for, and the reason is because if you look really closely on the MRI, and it doesn't project very well, but the scarring is actually so bad that there's scarring in the basal cisterns. And so this child would not have been a good candidate for an ETV, because even though the fluid's blocked in one area, it would have been blocked beyond the floor of the third ventricle also, which is where we do the ETV. This is a situation that illustrates the importance of being able to have the ability, anyway, to use an endoscope to get across these different septations. This is a situation where if you didn't use the endoscope to fenestrate these areas, meaning make a hole in these little loculations, then you'd have to put catheters everywhere to drain that fluid, at least 2 catheters. And that makes the shunt way more complicated. And so it's also important to be able to offer this. So that's just another thing I wanted to mention. I wanted to talk about, by the way, I talked way longer than I thought I was going to, and I'm sorry about that. That's usually what happens. I wanted to show, there's been some talk about brain shift after hemispherectomy and how it relates to hydrocephalus. And actually, this is probably something that would be more important to consider on a case-by-case basis, but I I just wanted to show examples that brain shift is something that's very common after hemispherectomy. These are just a couple examples. You can see some cases where you remove the entire hemisphere and there's not much brain shift at all. Other cases where you do the same thing and you see quite a bit of brain shift. And I think the important principle that I try to follow is I try to listen to my patients very carefully and their families, but I try not to treat the picture either. If the patient's doing well, even if the picture doesn't look perfect, then I generally will try to get more information if there's a problem. So this is a serious condition that warrants evaluation by a neurosurgeon. And I would recommend if your family member is a child to try to go to a children's hospital where they do take care of a lot of children with hydrocephalus. The reason for that is that not all of us are lucky to be somewhere where there's a big children's hospital. I understand that. And I also think that having your hydrocephalus care close to where you live is really important because shunts can break down. But if you can go somewhere that's a children's hospital that follows more stringent shunt protocols, infection prevention measures, I think that's important. Hydrocephalus can be tremendously complex. The decision of whether or not to treat can be very difficult, and I think the reason it should be difficult is because putting in a shunt should not be taken lightly. Shunts, once you get a shunt, you are shunt dependent, and so the decision to put in a shunt, given the infection rate, the malfunction risk, should not be taken lightly. Hopefully, the incidence of hydrocephalus after hemispherectomy is decreasing with some of these measures that we've talked about and some of the things that have been identified to cause hydrocephalus after hemispherectomy. But we don't know for sure, and we need more information. And so thank you, and are there any questions? Oh, yeah. Okay. Testing.
Hello. Okay. So my daughter is having an ETV this week, and shunt is always a possibility.
Yeah.
What are some side effects that we should look for if the shunt should down the road malfunction?
So, can you hear me okay? I'm using a new microphone. So, if a shunt stops working, can you hear me okay? Okay, maybe that one might be bad luck. We might want to, anyway. So, now I'm talking really loud. Okay, so if a shunt breaks down, the symptoms are hydrocephalus symptoms. And so it's nausea, vomiting, headaches, and you come in to get evaluated as soon as you can. That's why it's important to try to do it close to where you live, in my opinion. And it can also be things that are more subtle. Like you can have kind of a subtle blockage of a shunt that can just cause headaches over the course of a week. I did a shunt revision a few weeks ago it was a child that had headaches for 7 days and then came to the emergency room and there was a shunt block. And so those are the types of things. Rarely do I see people come in where the shunt block is so serious that they're really sick, like meaning in a coma or something. That's not very common because our shunt patients are typically brought in with these other symptoms that kind of occur earlier on. So it's not something where, because of that curve I showed, it's not something where the shunt stops and then an hour later you got serious problems. Generally, it'll kind of happen slowly. Yeah. Go ahead.
So my daughter they found hydrocephalus 2 years post-op from her hemispherectomy. And about a year after about a year after that, she started developing cysts within the resection cavity. She probably had like 8 or 10.
Yeah.
And she had to have shunt revisions, and they went in and fenestrated. What would cause the development of cysts so far out from surgery? Is it always infection, or are there other causes that would lead to the development of the cysts?
So in general, it's inflammation.
Okay.
And so it's probably inflammation related to the infection. And unfortunately, it can be a really long road because even fenestrating the cysts can cause inflammation to cause more cysts. And so multiloculated hydrocephalus, which is the type of hydrocephalus you're describing, is one of the most complex conditions we deal with. And so that's kind of, I don't think I put it in a slide, but one of our important jobs is preparing families for that. So that child that I showed who had the multiloculated hydrocephalus lives with a foster family, and the parents are incredible, and we spend a lot of time going over, this is what this is what to expect. We're going to have more follow-up appointments. We're going to watch things really closely because unfortunately, we're not out of the woods yet. And so it just happens to be a really difficult condition, and the septations can sometimes get worse before they get better.
She has another one that's developing that we're watching, so
Yeah.
it's kind of just been a process.
Sorry you're going through that.
Okay, after 17 years, we have the same shunt. Is there a chance that it's just not even doing anything and that you could ever just not need it anymore? We've heard of that happening to somebody else. Is that just a possibility, or will we how long could a shunt last? We're always watching for symptoms.
So let's say this. Let's hope we don't find out.
Okay, so just
Right?
keep watching for symptoms.
Because
we do now.
so sometimes, there are times where we see children come in where the shunt is it's broken in half, and it's clearly not working, but it's clearly been that way for a really long time because we got the x-rays for another reason. So that does sometimes happen. And the best thing to do is just to leave it. If someone has a broken shunt and they have no symptoms of hydrocephalus, you can, if it's clear that they're shunt dependent, like their ventricles are getting bigger, they're starting to get headaches, something like that, you fix it. But if it had clearly been there for a while, you can maybe monitor closely, or if it had clearly been there for a really long time, sometimes you can conclude that they are not shunt dependent.
So you have some kids, I know you said sometimes once a shunt, always a shunt. There have been times where kids
Yes,
have
that's
not
right.
needed it.
Yeah,
Okay.
I haven't seen a ton of those patients, but I think all of us have seen a few in our career.
Okay, thank you.
Yeah.
Are the symptoms of hydrocephalus different after hemispherectomy from what you would see, for example, somebody with an entire full brain?
That's a good question that I don't have a good answer for, because I actually have not seen a ton of hydrocephalus after hemispherectomy, because it actually happens to be a fairly uncommon condition, thankfully. Not for children who have hemispherectomy, but overall in the grand scheme of hydrocephalus. So many of the symptoms are going to be the same, like headaches, nausea, vomiting, all those things are going to be the same. If I had to speculate, the imaging findings could be different because you have such a wider area for the fluid to go. And so that's something that you would want to discuss carefully with your surgeon.
What is the difference, if any, between a hemispherectomy and a hemispherectomy?
Great question. So in general, like surgical terms, otomy is when you cut something, ectomy is when you remove something. So hemispherectomy is when you remove the hemisphere. Hemispherotomy is when you disconnect the hemisphere, in very general terms. So, and then in terms of hydrocephalus afterwards, the reason we started doing hemispherotomies is because there's this idea that you would have a lower risk of complications just by disconnecting things rather than removing all of it. And that's certainly what the literature would suggest.
Hi. I'm not even sure how to ask this question, but I have a daughter, by all accounts, who should be a very high risk of need for hydrocephalus. And of course, this is our fear. We live this every day. She's had 4 brain surgeries. Started out with a functional hemispherotomy, eventually converted to anatomical hemispherectomy on her 4th surgery, which has been about 9 years ago now. Imaging always comes back seemingly fine. Eye exam seemingly fine, but she is nonverbal, very sort of, low functioning. And so we threw up for many reasons. So as a parent, I'm really struggling with, is the imaging and the eye exams enough to really definitively rule out a concern, given that she can't verbalize to me if she has a headache, that she, like I said, she can throw up because we have problems with constipation and just slow gut motility and all those things. So I guess what I'm looking at is what information do I need? How do I best advocate for sort of continuing to stay on top of that and rule that out or rule that in and then, appropriately intervene?
Yeah. Maybe we can talk a little
Sorry.
bit. No. Maybe we can also have a more detailed conversation a little later on. But like the one thing I would say is papilledema, meaning looking at the eye exam, that's not sensitive or specific for hydrocephalus. So it's something we often use because it can provide us good information. If there is papilledema, then we've got to do something. But if there's not, that doesn't mean we don't have to do something.
But that's what I'm hearing. So you can't rely entirely on imaging. Yeah. You can't rely on that. If I don't have a child who's displaying symptoms or able to verbalize, then what am I left with other than just living in fear all the time?
So when I have a patient where I think there's still a chance they have hydrocephalus, but the imaging doesn't totally support it, which sometimes happens, and the eye exam doesn't totally support it, and I've done everything else I can do, then I will sometimes put in an ICP monitor, and for as long as you need. Sometimes you put in those ICP monitors and it's like, oh, okay, the pressure was in the 20s and 30s. This is hydrocephalus. But you leave it in for a couple days so that you really kind of see what things are like, and you try to have the child do as much of their normal activities as possible while it's in. So the other thing is, our hospital is part of like what we call the Hydrocephalus Clinical Research Network, and that's this group of all these children's hospitals that do hydrocephalus research together. So the one thing that's really nice is if I have a hydrocephalus patient that I'm not sure about, and this is such a complex condition, that I can send all the images out to the Hydrocephalus Research Network and get a panel opinion from the 10 best hydrocephalus neurosurgeons in the country. And so I've done that a couple of times when I'm not sure exactly what's going on, and that can be really helpful.
Okay, and then my last follow-up to that, because I also hear some of our kids
Can I say one other thing?
Yes.
I also would never hesitate to get a second opinion.
Yes.
Like, so I sometimes am seeing a patient and I'm telling them what I think, and they're looking at me like I have 2 heads, and they don't, and I think the key is that getting a second opinion is a good thing. And like the thing I like about Pittsburgh is that there are 3 other pediatric neurosurgeons in the same building as me, and I can offer that families can go meet with them and get a second opinion, because oftentimes you can get a completely different perspective from a different surgeon. So that's one thing you can do to advocate also.
Okay,
Anyway.
so I think what I'm taking away is it really needs to be all the imaging needs to be reviewed by a neurosurgery because oftentimes it's a neurologist ordering the imaging, and then it's the radiologist or whatever who's then comparing. And a lot of times they're just comparing to their previous X-ray, and so many of our kids, it seems like, have very slowly developing. And so if you're not looking back more historically, you're not recognizing the change, I guess. Is that fair to say?
That's fair to say, but then the other point I want to make is that hydrocephalus is a clinical diagnosis, not an imaging diagnosis. What that means is that we make a diagnosis of hydrocephalus not based on how a scan looks, but how a scan looks and the patient looks and other findings. And so you can't just, so that's another reason why it's really important to get a neurosurgical evaluation if you're concerned about hydrocephalus, because really we're the hydrocephalus experts in the hospital. The other types of doctors just don't see as much of it, and we see all the different types of hydrocephalus, and so I think it is important to see a neurosurgeon if you have a concern about some kind of problem with CSF fluid accumulation, like hydrocephalus.
My question has to do with, after the hemispherectomy brain surgery, the differences we see across the country at comprehensive epilepsy centers for monitoring for hydrocephalus. Some do external drains, some do Becker drains, and the many centers don't do anything at all. And sometimes the fluid, increases. I mean, it's expanding, and there's no external monitoring after that surgery. So and there's probably isn't any data, but what's your thoughts on that?
So I have noticed from talking to other surgeons that there's a not just in how the surgery's done, but how it's monitored right after surgery. There's a wide variation from center to center. My practice and the way I was taught to do it is to leave a ventriculostomy in place, which is one of those drains, and I leave it in for at least 5 days, usually longer. And I watch the fluid, and I check the protein count in the fluid every 3 days to make sure it's going lower and make sure that the fluid's becoming clear. And then you can use that same drain to measure pressure. And so you can make sure the pressure's not too high. I don't rely as much on whether or not they're getting like a pseudomeningocele, as long as it's a soft pseudomeningocele. Because young children, babies, they get pseudomeningoceles very commonly, and a lot of them go away with time after surgery. But those are the types of things that I do, and I think it makes a difference. It makes sense. Like the animal models of hydrocephalus, in the animal models, hydrocephalus is caused by like injecting, I think they inject iron into the ventricle or other types of debris. And so it makes sense to me that if I clear the debris out of the ventricle over the course of a couple days, that's going to help. So I think it does make a difference, though I don't really have a ton of evidence to support that.
So how long do you need to see these symptoms before you start to be concerned? For example, like vomiting, nausea, fatigue, those kinds of things obviously can happen from other things.
Yeah.
For example, my son, for like 3 weeks straight on Wednesday evenings, was really tired and vomited, and then would go to bed, wake up the next morning fine. Then then a week later, same thing. So he did that 3 times, and then there's a month span he didn't do it, and then he does it again. So just like how do you sort of parse that out?
Yeah.
And really, really tired, like really tired.
Yeah. Hydrocephalus is usually not paroxysmal like that, meaning it usually doesn't come and go. Mm-hmm. It can, but it usually doesn't. I'd say it'd be very unusual for it to come and go like that. But I would also say if there's any doubt in your mind, get an opinion from someone, because there's not much risk in just getting an opinion. I have like 3 kids, and so my wife is always texting me like, you went to medical school, what do we do with Ellie? And take her to a doctor, like I'm her dad, just get get the evaluation we need because I did go to medical school, but what if I'm wrong? You know, what if my knowledge, I have such a bias with my own kids, and so I always just, if in doubt, get an evaluation, and the system is usually pretty good, especially if you're at, if you're at a good place, usually you're going to get good care. But I would just get an evaluation, because something paroxysmal like that, what if there's something else going on? And I would just be speculating, but I would just get checked out.
Yeah, in that case, we actually did get a scan. After the third time, we got a scan. The scan looked fine, so yeah, it could be other things, but
The other thing with that, though, is a lot of times what happens, and it's unfortunate, is that as a neurosurgeon or a specialist, we kind of take care of our part, but we don't know enough about the other specialties to be helpful otherwise. And so I think that's part of the challenge is this is something that probably should be taken a look at more comprehensively. And it's best to do that through like a pediatrician, but the pediatricians sometimes get nervous and can't always make the most educated referral, especially in more complex patients. So it's still important to try to look for other diagnoses, especially if these symptoms are causing problems. But it does sound like the scan was reassuring. And anyway, does that answer a little bit?
Yeah. I was just curious of what the symptoms kind of. I was trying to keep it broad enough to.
Yeah.
But yeah, thanks.
You mentioned obviously headaches, vomiting, being lethargic. But how do you tell the difference between that and migraines without going in for scans every time? Because we do have a daughter who had a functional hemispherectomy, but she's now getting migraines every 30 to 60 days.
Yeah.
And obviously we're concerned, but at the same time I'm also concerned about the number of times she's going in for new MRIs, new scans. Is there additional symptoms to look for, or is this just kind of par for the course type of thing?
Migraines, what were we going to say?
No, they were saying par for the course.
No, well, I would say hydrocephalus looks very different than a migraine.
Okay.
But it depends on what your child's migraines are like, right? Like, some patients have these really classic migraines where, the first thing I ask a patient if they're in my clinic, if I'm thinking migraines versus, or is it that Chiari abnormality they have or something like that is, do you see flashing lights? Do you get weak when you have these headaches? Do you get tingling on your body? There are things like that that can really make it more obvious. But then if your child's migraine is a headache with nausea, vomiting, and they become sleepy, that's going to be difficult to...
Which that's what it is.
There are certain signs that can help you see, like for example, we look for bradycardia.
Which is?
High pressure lowers your heart rate.
Okay.
But that's something where hopefully you're in the hospital before that happens. So the scan would be pretty helpful, but it sounds like you've had a lot of scans.
She has probably 5 or 6 just for headaches every year or so.
Really?
Just because she's been getting more and more migraines.
This is tough. I mean, it's tough because I wouldn't rely. Well, that's you want something that. That can help with certain types of like low pressure situations. It can help you diagnose those. Yeah, the difference between a migraine and hydrocephalus is that the migraine usually goes away after a couple hours. Hydrocephalus will not.
So we don't go to the hospital till after
4 to 5 hours, but they found a way to break her migraines, but they don't do it till after the scans. That's the problem, and I'm concerned about the scans.
Yeah.
Anyways.
Okay, well, I'm very sorry about that. These can be very complex situations. And, the other thing is, I think the wrong thing to say is just stay home, right? Because you don't always know. Yeah.
My son has a shunt, and we're very thankful that we've not been having problems with it. But he was sitting at the table once working on something, and I came up behind him and just put my hand on his shoulder like this and was kind of leaning over, I guess putting pressure. And after a couple minutes, he said, I feel really sick. I got to go lay down. And he had been absolutely fine. He went and laid down for a couple minutes, and then he was fine. Mm-hmm. Was I putting pressure on his shunt, do you think? Does that make any sense?
I don't think so.
Okay.
You would have to put pressure there for like a really long time to get a change in the brain pressure.
Okay.
Like you'd have to put pressure there for like an hour or so.
All right. Thank you.
So my daughter has a shunt. She was actually one of those cases that the imaging didn't show. It did appear as though it was like an intermittent, gradual over time, and she was 5 years post-op before we got her diagnosed. Had a really difficult time finding somebody that would listen to my mom gut until somebody decided to do an LP and found that it was high. So, but my question here recently, she's had it for just over a year. We had been having some neuro symptoms, potentially hydrocephalus symptoms, everything but vomiting. So we weren't quite to that point yet, but had been checking her shunt externally, setting was fine, did a video EEG, just couldn't come up with anything without doing any further invasive testing. And then went and did another check a couple months later, and her shunt had actually reset. What have you seen that in everyday life can cause that? Or have you seen them just spontaneously reset? Could it be a mechanical error?
What kind of shunt is it?
VP programmable.
Which kind, do you know what kind of valve?
Certus.
I believe that's a magnetically programmed.
Yes.
Yeah, and I use the Strata valves, though Certus is, I know Certus a little bit. So being around like a big magnet is thought to reprogram those. The other thing is MRI scans, of course, can do that. Sometimes we'll see somebody whose valve was at the wrong setting. And a lot of times we can't figure out why, but the key is just avoiding really strong magnets. And I'm not talking like an iPad or something like an MRI scanner.
So we don't have anything that fits that during that period of time. So it was concerning. But one thing that she did go through was the video EEG. Would there be anything in those wires or the box or anything that could interfere, or not very likely?
I don't think so.
Okay.
Certainly not at the centers I've ever been at before.
Okay. Thanks.
Hey, I just want to ask, post-shunt, my son's imaging didn't show hydrocephalus either until it was extreme. So post-shunt, if they're having symptoms, do you depend on the imaging again? Is it just a comparison from imaging to imaging with the MRI, or do you ever push to get a LP again?
So I actually don't. I prefer not using lumbar punctures, and actually people in my group do use them. But the reason I don't like lumbar punctures is because I'm not sure it's as reliable of an indication of the pressure as putting in a pressure monitor. And my take on it is, like, even every time you do an operation on that shunt, whether you're revising it or putting one in, the risk of an infection resets to that 5%. So every time you operate, it's like 5%, and slowly goes down over the course of 2 years to where it almost gets to zero. But I sometimes use ICP monitors to try to figure that out. But you look at all the data together, the imaging, look for papilledema, and we know that these things are not bulletproof. But if I'm really convinced that I think someone's having hydrocephalus symptoms, even if they have a shunt in place and the shunt seems to be working, or if I'm not sure it's working, then I'll put in an ICP monitor.
Just a follow-up question on an almost entirely different topic, but you said go to a children's hospital, obviously, but would you also live in an area where there was a children's hospital with a surgeon who's done a hemispherectomies if your child had a shunt? Is that?
Say that one more time.
Would you specifically look for a surgeon who has done a hemispherectomy, I guess? If your child has a shunt with a hemispherectomy.
That's a good question. I think the ideal situation would be to be somewhere where the surgeon had experience with hemispherectomies or hemispherotomies, and then I'd say all well-trained pediatric neurosurgeons are pretty good with hydrocephalus and shunts. But that's a really difficult thing to do, right? Because
it limits our places to live.
Like, we can't all live in, the places that do a lot of hemispherectomies. And so I'd say that we're all pretty familiar with, like, postoperative hydrocephalus, and that being able to technically do the shunt is fairly, like we said, it's simple but not easy, but it is a fairly straightforward operation that everyone could do. And I do think it's important to do it close to home so that there's good follow-up. And just in case one of those things that can happen does happen, you're somewhere close where you can go and get an evaluation, and that would be my opinion.
Okay. Thank you.
So I think it's okay.
I have a 10-part question. So
All right.
I'm just kidding. I wanted to know, so we've been fortunate not to have hydro, and my daughter's almost 6 years post-operative. And so how does the curve go? Like, if you haven't had hydrocephalus and you're 6 years out, does the chances of it occurring go down very significantly, or is she still at the same risk?
So the answer is, I don't think that's known. What I would guess is that the longer you go without hydrocephalus, the better your chances of not developing it. That's what I would guess. Because certainly we see hydrocephalus acutely after hemispherotomy or hemispherectomy, where it happens right away, and after the operation, patients leave the hospital with a shunt. But I would say the longer you go without a shunt, probably the better your chances you're not going to need one. But I don't have any data to support that.
Thank you.
Oh, another thing I would say, though, is that even though that's what I believe, I would still want to see my hemispherotomy patient once a year. My goal has been to see all of my epilepsy surgery patients once a year, just to make sure things like this don't fall through the cracks, because they can, right? And so I do think it's important to be followed by a neurosurgeon if you're at risk for hydrocephalus.
And if you can't get a CT or an MRI scan anymore, my daughter has a cochlear implant. Is a CT scan pretty reliable for the hydro?
Yeah.
Okay.
Yeah, it's pretty good. The thing we get concerned about is radiation exposure. So every time you get a CT scan, the radiation exposure you get is about the same as if you were to fly from here to London or something. So it's about that kind of radiation exposure. So it's really low, but it's not nothing. And so the concern we have is actually particularly with hydrocephalus patients who are getting scans, CT scans all the time. We try to move away from CT scans and move towards like faster MRIs. But if that's not an option, CT scans are good for looking at the fluid spaces in the brain, and just, you know, we try to avoid the radiation risk, but you know, it's not too bad.
You've talked about parsing between migraines and hydro. If the only symptoms are aggressive behavior and a headache that seems to resolve pretty quickly within a day, then an imaging MRI is fine. Can I safely rule out hydro, or do I have to look for other symptoms of hydro that you'd put on the slide? What would you suggest?
I would look for other symptoms in that situation. Yeah.
My son had his hemispherectomy at UCLA, so he had that version about 8 years ago. And last summer, he started having kind of similar intermittent migraines lasting 2 to 3 weeks, not every day. One day he'll be fine, the next day he's down and out, can't get up, vomiting. It also happens like right after he falls asleep and before he wakes up, and the pressure's so bad when he vomits that it was also pushing out. And he's fully potty trained, but also pushing out bowels. Mm-hmm. And so he had a scan done, and they found that he had a fluid-filled cyst in the resected area of his brain, a large one, almost filling up the whole space. And so now we're 10 months after that first run. He's had him every few weeks to a month. Missed a ton of school, but then in between, he's totally fine. I mean, he's here, he's running around. So now they're doing that in 2 weeks when we get home, cyst fenestration and an ETV. Mm-hmm. But I'm just curious too. I mean, and the scan says it looks fine, his ventricles, for not being hydro, and so they think it could possibly just be this cyst area.
Yeah.
Does that sound right? And I mean, it just sounds similar, and he's getting the same thing, MRI under sedation each time, or he's had 3 this year to try to figure out what's going on.
I've seen that after hemispherectomy, where a cyst forms, and the cyst, you know, some of these cysts have like a one-way valve, and so they fill up with fluid, but the fluid doesn't leave, and so sometimes these cysts can get bigger and cause pressure, and so that is something, like, I haven't seen the scans or anything like that, but that is something I've seen, and so it's something to look into. Yeah.
The intermittent issues, is that consistent with that?
It's a little tougher to say. Yeah. Especially without having seen the scans or, yeah, sorry about that.
Okay.
Anybody else?
Another thing I'd say is my email address is like really easy to find on the internet. If there's a question you have that you forgot to ask and that you wanted to ask, feel free to email me.
Yeah, that's fine. I'll make it quick. So I know it's a common theme among a lot of us that our kids have intermittent issues. My daughter, before her shunt was placed, would have like a headache one day. She'd never had headaches in her life, and then be fine, and then vomit for a day or two, and then be fine. And then eventually, like, it hit the fan, and she needed a shunt, and she had papal edema, and it was, like, able to be officially diagnosed.
Yeah.
But that is a trend we see where there's random, like, intermittent issues, and some of them are often really vague. Like, for her biggest indicator of pressure is actually she'll have a toileting accident, which is, I mean, she never has those, and she'll have an increase in aggressive behaviors. And so are those kinds of symptoms something you see often, or are they pretty rare to see those subtle? Like, the only times when she has like the typical presentation is when it's gotten really bad, where she's throwing up and can't sit up and her head hurts, and I mean, she's miserable. But before that, there seems to be this like slow build of very vague. Now we know to act early because those toileting accidents are very indicative for her, and the behavior is like, we know what to do now. But do you see that often where your patients have like really subtle, vague symptoms?
In the setting of like a shunt, if you do have a shunt, sometimes you can see subtle symptoms because the shunt is like slowly getting blocked, or like a couple of the holes of the shunt are blocked, but not the whole thing. So you can see that. Yeah, that's certainly something you can see. Yeah, definitely. And aggressive behavior is something that I'd say it's not like specific for a hydrocephalus problem, but irritability is something that happens when you have headaches, and so especially in children that are not able to communicate, they might just become very irritable, and that may manifest as aggressive behavior.
Yeah, she used to have a lot more aggressive behaviors, and when her shunt was placed, they just plummeted. And she's not the type that complains of pain, and so could she have had pain that she wasn't expressing, and then,
Yeah.
treated the behaviors as well.
All right. Thank you, Dr. Abel, for all the time today.